right, we're set? Okay, all set. All right, good morning everybody. Let's get started. We're a few minutes behind and we don't want to pressure anybody. So our next speaker has a very unique and exhaustive background, which I will attempt to summarize. And she's watching here because she doesn't want me to say too much. So I'm going to have to cut some of the essential stuff so I can say what I really want to.
Good.
So the first thing about Christine is that she's a clinician. She got a bachelor's degree in nursing, then a master's as a certified registered nurse anesthesiologist, and then she also got a doctorate from Virginia Commonwealth University. And then when she was practicing, she also got a Lean certificate from University of Michigan and a health service management certificate from Kellogg. She's garnered many awards over the years. She's written over 40 papers. She's given over 100 presentations here and there. And in her experience, of course, she started, as I mentioned, as a clinician, and I'm only touching the surface. She also became, of course, a chief nursing officer, a chief operating officer in a 300-bed hospital, and eventually worked for the American Association of Nurse Anesthesiologists, where she started to practice on the political side, legislative and regulatory interventions. And all of that while raising 4 daughters. And she that's an accomplishment, right? And we were very lucky when she joined ABC, the Association of Blood Centers of American Blood Centers, as the CEO a couple of years ago in 2013. So she's bringing an entirely fresh perspective, but as I mentioned, with a wealth of experience in how to interpret it. So I'm really looking forward to her presentation. Welcome.
Thank you. Thank you, Pascal. Well, first of all, I want to say just how delighted I am to be here and to see such a full house. Thank you all for being here. And I want to particularly thank the America's Blood Center's members that are in the audience, the hospital blood bank members that are in the audience, and the American Red Cross members that are in the audience, and the vendors that are in the audience. And is there anybody I missed? Raise your hand if I missed you. Okay. And Pascal, thank you for the nice introduction. I saw a lot of head nodding when he said that I have 4 daughters, and one of them is getting married this Saturday. So I have a lot of organizing this week to do. So I'm very happy to talk to you about hot topics in the blood community. Well, anyhow, it's just a pleasure to be here. It's so impressive to see the number of people at your state meeting and to see how involved everybody is and how everybody's working together to really continue learning. I think that's really a wonderful thing. So a little bit about America's Blood Centers. We are North America's largest network of nonprofit community blood centers. Our members they're nonprofit community blood centers. Some of them are really big and they encompass numerous states. Some of them are little, small, very tiny community based. I know I visited a blood center in Eureka, and that is Northern California, and there were, I think, 50 employees, and the community had every year given the blood center a bowling pin with a costume on it, like a little outfit. And so when you went in their lobby, there were all these bowling pins with outfits, and it was very charming. So we go from just very high-tech NIH-supported researching institutions to small community-based blood centers. Operate more than 600 blood collection sites in the United States and provide over half the blood supply in the country. So we're very proud of that. Plus we have a member, Hema Quebec in Canada, which I think is about 25 or 30% of the blood supply. So 6 million whole blood collections annually, and we support 3,500 hospitals and healthcare facilities. So my story begins with the fact that our board about 2 years ago got together and spent 2 days in strategic thinking. And they called it strategic thinking because it really was immersing themselves in what is the future of blood banking, what is the current state, where do we want to go, how do our members feel. So it wasn't strategic planning as we all know it. It's some rendition in our life where there's a bunch of newsprint on the wall and you do a SWOT analysis and then you come up with a plan and then you put it on a shelf. The board really surveyed all of our members. I personally talked to all the CEOs across the country, found out what the concerns were, what the barriers were to being successful, what the challenges were, what the great things are that are happening, how they're innovating, got the whole lay of the land, and then spent 2 days looking at all that, kind of culling over it. And so the board did come up with some big aims as a result of that strategic thinking. And these are the aims that were important to our members: advocacy excellence, data-driven excellence, education competency development, association model redesign, and governance excellence. And so what I'm really going to talk to you about today, I'll briefly touch on those, but since I'm talking about the current state in the blood community, I probably will spend more time on advocacy excellence than anything else. So this is a picture of some of our members just in March with Congressman Farr. He's the ranking member of the House Appropriations Subcommittee that is the appropriating subcommittee for the FDA. So they basically pay the FDA's salary. And so we've established a relationship with his office to try to get things done as far as our issues. So in terms of advocacy excellence, there were 4 main areas that ABC is really focusing on right now. And I'm going to talk in greater depth about 2 of them, and they are plasma flexibility and the value of blood, or sustainability of the blood supply. So we have one more immediate goal, and then the second is really, I would say, a longer range goal, probably 3 to 5 years. So let's talk about plasma flexibility first of all. And what do we mean by that? Well, we are interested in changing the regulations. Right now, I'm sure you're aware that the regulations allow blood centers to use recovered plasma if it's not transfused for further manufacture for life-saving component or products. And so the issue for us is that if the plasma comes from apheresis, if it's concurrent plasma with other components, or component plasma, which is plasma alone from apheresis machine, we can't do that. That we have to store it for about 1 year till it outdates, and then it can be sold for further manufacture to the fractionators. And so plasma is plasma, it's really the same product, and the FDA regulation says if it's from whole blood, it can be immediately labeled and sold. If it's from an apheresis machine, either concurrent or component, it has to outdate. And that just doesn't make any sense, and everybody we talk to about it says that doesn't make any sense. So it's not as if it's something that there's some other angle to it. It's really just at face value, does not make any sense. So a year ago, January, our board said, no, we're going to really pound this, we're really going to work on it. And actually, historically in the industry, there is 12 years of background of going to the FDA and asking to change this. So for 12 years, there's actual documentation of letters to the FDA, committee meetings talking about this, et cetera. So this is not a new issue. And it's not an issue where there's controversy. What we want to do is make it easy for the FDA to change their regulation, because if it's hard, then they don't want to do it. And so what our goal has been to make it easy for them to do the right thing. So to start with, we really needed to get some attention. And so to do that, we worked with Congressman Farr, and last March, not this March 2015, but 2014, we were able to get in the House Appropriations Committee report out a statement saying that the House Appropriations Committee directs the FDA to fix this. And the language was a little fancier than that, but it basically said that this doesn't make sense, you need to fix it. So then we followed up and we really looked at, as you do in advocacy, kind of a grass tops approach, and looked at who else is an influential group in the blood community, and who else should we ask about this, and who else can we get to agree with us. And so we did actually get everyone in the blood community to agree. We were able to get the AABB, we were able to get American Red Cross, ABC, of course, we took the lead in this, so we were definitely a signer of the letter. But we also got PPTA, the plasma protein folks. We got the IPFA, the International Plasma Protein, because they buy this, they're interested in this. And then we went to AdvaMed, those of you that are in the industry here, and talked to them. And they were the last ones to sign on, but they did sign on. So we really had the whole blood community. And when you look at an advocacy strategy, it's really important to know if somebody opposes what you're doing, because they're going to be right after you, complaining and saying, don't do this. And so we found nobody that opposed what we were doing. So this was such a low-hanging fruit for the FDA, because they're not going to get letters from Congress saying, why are you doing this? This is going to be the downfall of something or another. So it's very easy for them to do this because nobody is against it. We wrapped it in a bow. Everybody is for this. So we had all of these groups sign on to a letter with us, and we sent it to the administrator for HHS and to the FDA, very high up. At the same time, we reached out to the patient groups, and there's a group called A+ that consists of 10 patient groups that are dependent on the products that are made from plasma. So hemophiliacs, the people that are immunosuppressed, they have a group, and et cetera, et cetera. There's a lot of little sliver groups that really their life depends on these products. So we talked to them, and they took our letter and they wrote their own letter, and they all signed on. So we have all the industry, we have all the patient groups, all saying to the FDA, you have to change this. So that led to a meeting. The FDA contacted me and said, we'd like to meet with you. We understand this is important. But I'm not sure if it was a combination, but the House Appropriations, that was really, because they have to answer the House Appropriations Committee. Although I have a funny story about that, since I do have time, and that is just the timeline of the FDA, how different it is from other human beings. Because and really other agencies, even I've worked a lot with CMS, and they are different. They are not as quick in responding. But I was working with the chief of staff in this in Congressman Farr's office, and so we were really excited. They put this in the report. They let us, suggest the question, and so it went in the report in March. It said, you have to respond in 6 weeks. So I'm just watching the calendar, and so about 5 weeks after the report came out, Rochelle, the chief of staff, emailed me, and she said, the FDA responded to the request, and she had an attachment. And I was like, oh my gosh, they're a week early from the 6 week. I was just incredulous because everybody says they're pokey and this is pretty good. So then I opened the attachment, and it's this long diatribe on platelets. And I thought, platelets? I thought the FDA, they couldn't mix up plasma and platelets. They couldn't do that. And so I'm reading this about platelets. And so I couldn't figure out why they had responded about platelets. So then I thought, I should look back at the committee report from 2013, the previous year. And so now this is 5 weeks after the 2014 report. So I pulled up the 2013 report from the Federal Register, and I'm reading it, and sure enough, at the end, they directed them in 6 weeks to respond to a question on platelets. And so it was a year and 6 weeks that they were responding to the question on platelets, and now we had another question about plasma. So anyhow, that's just a little anecdote about just kind of their timing. So we had the meeting with Karen Mithen. It was a very good meeting. We had someone there from the patient group, from the hemophiliac group. We had Richard Benjamin from American Red Cross, myself. We had Teresa Wigman from AABB. We had Dave Green, who really did he was our president at the time, great job talking about the efficiency of doing this, that this is exactly what we want in healthcare reform, something that doesn't take more resources. You don't have to build another facility, you don't have to buy new equipment, and the greatest resource of all is the donor. You don't have to get new, you have somebody sitting there wanting to donate, and you can just take this as well as what they're donating. So it's like the perfect example of healthcare reform, low cost, efficient, that can provide something in patient care. So he really made that point. I thought it was a very good point, but everybody made excellent points. So at that meeting, it was the first time really that I think at that high level there'd ever been an audience, because it had always been lower. And so what they brought up to us were, I think, what's representative of how the FDA has been thinking about this. They asked, what would you do if it's on the front page of the New York Times that the FDA just approved something that takes blood from patients for free when they could get paid for it if they took it somewhere else? And so they want to know, how would we answer that? How would we write a letter to the editor about that? So the PR part of it, they were worried about. And the whole idea of, and the ethics, the keynote speaker today talked about ethics, how that's playing a big role. So what is the ethics of that? And what should we be required to tell donors coming in as far as their options? And and should we be required to tell them that we would be selling this product? So that was kind of a big issue for them. So we did make the point, and then they said, well, these things take time, and we did make the point, it's been 12 years, we brought all the documentation, we said, this isn't new, and it's not controversial. It's like perfect, because you've worked on it for 12 years, theoretically, and nobody disagrees with it. So that led to another meeting with Jay Epstein, who is really more the can-do person. He's at the lower level, although he's very high level, but he is not as high as we were, and his team is the one that has to write the regulation, do all that stuff. So we met with him and all his lieutenants and the woman that does all the language and writes these things. And so that was a little more difficult meeting because they were really pounding about this idea of the ethics of it. And so we said, we can go along with something in the consent that would say that if your product is not used for transfusion, then it may be sold for further manufacturing for life-saving products or something like that. So that might be what we have to do. We offered that we'd be willing to do that. They are concerned about labeling the product. So now we got to the nitty-gritty of really what the problem is. They're concerned about labeling the product immediately because they are locked in a box, because their regulation about source plasma is very specific, and it says if it's labeled for further manufacture, then it's defined as source plasma. So their own regulation has put them in a box where they didn't anticipate this question coming years later, and now we're saying, well, no, we're not talking about frequent donations. We're just talking about in the normal course of a blood center working and we have a lot of disenfranchised donors that want to donate, but because of trolley and all that stuff, we're saying, well, you can't donate anymore, but now they could. And so some of these, it would really be efficient just to have plasma donated, but in an infrequent, in compliance with the regular donation schedule. So we're really talking about something different than source plasma. If our members want to do source plasma, then they get a source plasma license, they meet all those requirements, that's something different. So they explained to us, well, we can't let you do that like that because we're wrapped up in our own undies kind of with our regulations, and so we can't let you do that. But we could let you label it for transfusion and hold it for some period, not a year, and then relabel it as for further manufacture. So then we started talking about, well, what do you mean by that? And so we said, well, okay, we could do that, hold like reserve in case it's needed for transfusion for 48 hours and then relabel it. And so we were thinking like 30 days. And so we didn't really, we said, well, our position, it should be 48 hours. So we left that, and that is that's like issue number 2 that they're kind of working on. Then the third thing that we don't agree on is they said, well, listen, as a first step, let's just do this for concurrent plasma. Let's just do this, if you're already taking platelets and plasma, let's just do it for that. But you can't just do plasma. And we said that's really absurd because it's not very lean. Why should we have to come back to you again? We've all agreed this is what we want to do. Why are we breaking this into steps where you don't fix the whole problem, you just fix part of the problem? And so they said, well, we've just been thinking about it this way. So the good news is then in January this year, the FDA priorities came out. I'm sure all of you read those every year. They're guidance priorities. And this was listed for the first time as a guidance priority, which means they're going to publish a guidance this year on it. So they are going to do it. That's good. And when it comes out, I think we've looked through kind of the window of their brains, and I think it's going to come out saying some delay, maybe 30 days. So we'll have to write and say no, 48 hours. And we're going to ask all of you to write and say no. And then they're going to say probably we need something in the consent, which we've already sent them language that, that seems reasonable that you would inform a donor that they would be, having that possibility that their gift would go either to transfusion or for further manufacture, that it would be sold. It's interesting because we don't do that with the plasma that's recovered. We don't have that. And we made the point it's no different, but they make a distinction that they think that it is different because of the intent. And then we're going to go for the concurrent and the component. That'll be our position. They might come out with something just for concurrent. So we do know they're going to come out with something. So rolls around again, it's March. The House Appropriations Committee just met, and I was at the hearings and talked to the people there. And so then afterwards worked with Congressman Farr's office again, and we just last week finalized the language, and they are going to put it in the report this year, acknowledging that the FDA did have it in their guidance priorities, but directing them to prioritize this among their priorities and to report back in 6 weeks. So, so now that we have that, it's going to come out probably the end of May. Now that we have that, then we're going to go. We had it recently, our day in Washington, and have our congressional supporters with that in hand write to the FDA and say, come on, you've got to do this. We'll probably get another letter from our blood community and our A+ group saying, it's been a year. Congress has said again, this has to be done. It's in your priorities. Where are we at? Can we, get this the top of the priority list? And they've got some big things this year. The MSM thing, they've said that's in their priority list. The Babesia, they're kind of looking at that. They have that bacterial testing that we responded to. We're waiting for a final rule on that. So they have a pretty full docket. So that's an update on plasma flexibility. Okay, so now let's get more esoteric. Our keynote speaker said, we have to be big thinkers, 20,000-foot view. So value of blood, what are we talking about? Well, we all realize in the blood community that there is a huge perfect storm coming as we continue to have grinding down from cost pressures, from our expenses going up and our reimbursement going down because hospitals' reimbursement is so tight. And so we know that this cannot continue and we cannot sustain this situation. It really is getting to the point where we are starting to erode some of the infrastructure of the blood system in the United States of America. I can't remember the exact numbers, but I meet with the American Red Cross, Chris Carauda. We try to meet every month, and he is going through an incredible reduction in force in the American Red Cross across the country. And I can't remember the exact number, something like 1,000 or 1,500 people. It's huge. American Red Cross is huge, but that's a huge number. And then the ABC members are reducing. And where do you reduce? Well, you generally reduce things like education, sometimes quality, lower paid jobs, but all that erodes at the infrastructure of the blood supply. It really does, because right now you are cutting back, and you get to a point where if you needed to surge in this country, how are you going to do that? You don't have the extra phlebotomists, you don't have the extra recruiters, you don't have the extra people to make that happen. And really, should the blood community pay for that ability to protect the country by surging? Should hospitals pay for that? Who should pay for that? So that's one way it erodes at the future of the blood supply. I really believe nobody is watching that. And in 5 years, if we had some situation can we increase right now 2%? Probably 3%, 5%, 10%? Probably not. So what's the sweet spot, and who's responsible to make sure that we can do that surge? In other industries, like even the pharma and the batches of pharmaceuticals that we have and different things, there is a government overlay that allows for that surge capacity, because that's part of the overall planning. But we've always just been able to do that in the blood world. So I think we have to take a look at that. Secondly, what about new technology? Can we adopt pathogen reduction? I'm going to show you some data on that from our members. Can we test for additional pathogens? What if something comes out that's just so much safer and so much better and so much more expensive? Can we afford to implement it? Well, what we're hearing from our members is no, they really can't. And what we're hearing from hospitals is don't expect us to pay for it. We can't afford it. And so who is responsible to pay for innovation in an industry that is against the wall as far as cost reduction? Well, what should the model be for that? Because it does affect it is a population health issue. It doesn't just affect the recipient of the blood. If recipients have more pathogens and infections, it affects the population. So where does the responsibility lie for that? And then the other issue in the value of blood is really the basic insurance value of blood, because in hospitals, I was a hospital executive for over 20 years, something like 60% of everything we did relied on blood availability. We didn't give the blood, but just as an anesthetist in the OR, if I started a day of total hips, we wouldn't start one of them, and we would do 4 or 5 in a day without 2 units of blood. Cross-matched, ready to go in the refrigerator. We wouldn't start the case. The surgeon wouldn't start the case. Maybe in that day I would give 1 unit or 2 units, but there would be 8 units that we had to have, and it was almost like stock options. You had the option to buy it, and then if you don't, except in stock options, you pay for a stock option. But in blood, you don't pay for it. The hospital didn't pay for it. You know, you had it on the shelf, but if you didn't use it, you return it. So you had the option without any cost, really. And that's, many of us have gotten in that situation where that's how we, because of our relationships with the hospital, that's how we provide the service. So that's another kind of issue in terms of sustainability. Can we continue to have the insurance value of blood when it's not used, and the whole infrastructure for providing that falls on the backs of the blood centers? So we know the question, but we don't know what our ask is. In Washington, D.C., there's something called the ask, and everybody wants you to make the ask. They're kind of waiting for you. Like, you don't go in and take up their time and blah, blah, blah. You start the conversation by saying, I'm here today to talk to you about the value of blood, and I'm going to ask you to support research so that we can make sure we have a sustainable blood supply. It's going to cost about $500,000. I mean, you need to know the ask. Well, to change reimbursement for blood, we don't know the ask. I don't know what right now we'd ask for. So we decided, Dr. Katz and I, to talk to some think tanks. And so we spent most of 2014 talking to different people that study questions like this, kind of healthcare economic questions. So we narrowed down 5 think tanks that we think could do a good job. Number one, figuring out what the gap is between the current blood economy and what it needs to be. And then that should inform us as to what the model should be to pay for blood. And they had really interesting ideas. One person said to me, Huey Reinhardt, I don't know if any of you have heard his name, but he's a very famous healthcare economist. And after he listened a little bit, he said, well, I see the problem immediately. He said, it's a Benjamin Franklin problem. And I said, what do you mean it's a Benjamin Franklin problem? And he said, well, Benjamin Franklin noticed that in the little town where he lived, when there was a fire and the wooden house was burning down, the fire people would come with the water, and then they would negotiate with the homeowner how much to pay for them to put out the fire. And Benjamin Franklin said, well, this doesn't make any sense because all the houses are wood. And so if this house burns down, the next one's going to burn the next, and the whole town's going to burn down. So Benjamin Franklin actually invented the fire department, the municipal fire department. Did you know that? He invented a lot of things, but he invented the municipal fire department. So Huey's point to me was there's a greater good to blood that is not just the commercial aspect between a hospital and a blood center. And so that's really an interesting point. One of the other think tanks said, we should look at the utility model. I mean, look at electricity, for example. In Michigan, we pay DTE, Detroit Edison, for our electricity. So we use it in the house, we pay for it. But the federal government pays for the grid, the regional grid for the United States of America to protect us so we have energy. Because there's a greater good as far as our national security. If we had no lights and we were all in the dark all the time, that would be a very serious security concern. And so actually I just read an article in the Wall Street Journal. There's something that they're really worried about in the federal government. It's something like zapping up in the sky. I forgot exactly what it is. That could wipe out our grid. So I didn't want to think about that. That was an interesting article because they said they've modeled it and the entire population would be wiped out in 1 year, and it would be from 2 things. One would be disease and one would be civil unrest. And in 1 year, there'd be nobody left if there was no light at all. So think about 24 hours, no heat, no light, no electricity. Anyhow, I diverge. So we've got these 5 proposals, and wouldn't you know it, they range in price from like $180,000 to about $400,000. And wouldn't you know it, we like the $400,000 one the best. And that is the one by Rand Corporation, who is very highly respected, has a lot of publications in like health affairs and all these health economic journals, the Harvard Business Review. So we've got somebody that can do the study and do a really good job, and now all we need is $400,000. So we established a Value of Blood committee in ABC, and they reviewed these proposals. They agree the most expensive one is the best one. And so we've looked for funding opportunities. We've been to HHS, and we've talked to Jim Berger, who actually has taken some action that's very helpful. One thing is we applied for an evaluation set aside at HHS, and unfortunately we just learned 2 weeks ago we didn't get it. They fund, it's supposed to be for evaluation of new ideas, so we thought it was perfect. And they ended up funding the food pyramid, and they funded childhood obesity. And I don't want to say these are boring things, they're important things, but I think they're things we're already paying for. I was surprised when I saw what they funded, the food pyramid. I mean, that's been around since I was in kindergarten, so it's just, that doesn't seem that exciting, but it sounds like anyhow, we didn't get the money. But Jim is in charge of the ACBTSA, he staffs this big committee that advises the secretary of HHS on blood issues. Jay Menitov is the chair of it. And so working with Jay, we agreed that we should establish a subcommittee of the ACBTSA, which has been done, to just look at this issue. And we think the subcommittee may recommend the study be done, and then we could take that on the Hill to get funding and get appropriations money, because we'd say a subcommittee of the HHS recommends that this study is important. So it's all these baby steps. The strategy it's like spokes in a wheel. It's not just one approach. You have to really be working a lot of angles to get something like this done, because this is really a 3 to 5 year thing. We also went out to the NIH, talked to Keith Hoots, who's responsible for all the blood research, and he really told us, frankly, he supports it. If he's in a meeting with HHS, he'll say, this is really important, we have to do it, but they're doing more basic science blood research there. They're looking like at the cellular membrane and trying to figure out, the effect of who knows what, something on cell membranes. But anyhow, so they probably would not do healthcare economics research. So where we're at right now is we are in the process of writing a grant for BARDA, which is another agency that has something to do with national security, and we think that might be a good angle. So that is what we're doing right now, and I'm meeting with the head of BARDA to brief her on this issue so that when our proposal comes through, she'll be familiar with it. So that is the update on our Value Blood project. Okay, just quickly, some of the other objectives, because I think this does have something to do with what's happening in the industry. For the data-driven excellence aspect of our aims, we have a data warehouse. ABC has a data warehouse which consists of over half of our blood collections are in our data warehouse right now. And so this year, after we did some due diligence and made sure that we had data integrity, and we have a colo in Texas, and we have really everything we need to do. We had some consultant recommendations. We had them come in and tell us what we need to do to really be at the level where we can expand and go forward. We did all that, and now we have set up some subject matter experts from the ABC. We have a committee. It's called a RAC, Requirements Advisory Committee. They're coming up with the business intelligence reports that we're going to be providing. And we have, as I said, over 50% of our collections. We've just reopened it. And so now we are working with another BEX to get their scripts written and bring up that next group, that next cohort of our members. So our aim is to have 100% of our members putting their data in the data warehouse. And then it has a lot of impact, I think, on industry. There's a lot of information internally for blood centers to do better and benchmarking, as well as externally in advocacy. Data is power, and it's very powerful. I'm so grateful that the American Red Cross is working with us on these issues, because to go on the Hill and say, I'm speaking to you on behalf of almost 100% of the blood collections in the United States is really powerful. So as we get more data, that will also be stronger. Here's just the top 5 business questions right now that the RAC is looking at. You can just read those. And this is just the beginning. This is just a sample data warehouse report. Will there be enough donors in 2020? And so they looked at the percent of donors by age over time, and they're finding some very interesting trends. That when you look at the percentage of donors, the 35 to 54%, the 35 to 54-year-old donors who make up our greatest percent of donors are actually decreasing in number. And then you can see the rest of the data. Okay, education and competency development. Just to mention that we are developing the API, the ABC Professional Institute, and it's really one-stop shopping for all things blood-related for learning. So if you can see, I don't have a pointer, but on the right, there's a little diagram, and it's really showing you the portals. So it's for access to face-to-face learning, you can go to the API. For self-learning, self-taught, you can go there. To have access to our 16 listservs, you can go there. To be put in touch with maybe some content experts, you can go there. And then for our publications. So we're very excited about this. This is the new website. This is what it's going to look like. We just did introduce a great app on for cell phones at our meeting in March. and got very good applications. So as we introduce the API, we will have a mobile app that you can access the API offerings. And what we have heard, something you might be interested in, what we've heard from our members in terms of priorities, this Blood Banking 101, we had 80% of our members said if we had it, they would use it. And what it is it is a learning program for people that come into the blood banking industry and have never been in it before, people like me. And it's not just phlebotomists, it's not just entry people, it's people that could be board members, that are bankers, and they don't even know what ABO is, or let alone, double reds and apheresis and some of this stuff, pathogen reduction. And so they don't know what the FDA is. They don't know, they don't understand the supply chain of what happens when you put a needle in somebody's arm and take their blood, what happens next. They don't understand testing. So this is something very hot that our members say, we really need this. So we've already done the curriculum. We have a committee working on this. And so by the end of this, our fiscal year this year, we intend to have this product available so that, because our members say we don't do a good job at this. It takes a lot of time, and we're probably missing things, and so we will have a comprehensive Blood Banking 101 for people coming into the industry from outside. Another thing, secondly, our members said the next priority was Blood Banking Leadership Certificate. They feel that they can't, and we want to make this available outside of our membership as well, that they don't have time to take 2 years to get an MBA, that they don't have the money, blood centers don't have the money to pay for this education. And so we want to offer something that is, allows people with promise to be promotable in their blood center and to advance in their blood center. And to do that, you really need something on change management, something on leadership, something on HR, something on finance, something, the basics, something on quality, something on lean, just the kind of the general milieu of business knowledge that many of us, if you're promoted as a clinical person or as a tech, you never really had that. So that's our second thing that we're gonna offer. And then these are just some other things we're doing in that area. And then we've done a lot to improve our association and make ABC a stronger organization. We have consolidated our office space, we introduced the hospital-based associate member, and we have now provided for our members a member value report. This is what it looks like. The first page talks about what we're doing as an organization. The second page, we are able to, through our CRM, say exactly how many people have called ABC, what they've called about, what the big issues are from your blood center. So this is what our members got. And then we had some fun along the way. We do some fundraising, and this year we did, I don't know if you recognize any of these folks, but this year we did a talent show, and we raised money. You could vote. And as a matter of fact, there's somebody here, right in the front row, who sang a beautiful, lovely French song. It was so pretty. It was so pretty. And it ends up that it's a very famous French song. So we raised $31,000 for the API that I was just talking about, for developing our educational programs. And it was just wild. Actually, the belly dancer had been a Miss America runner-up. She was Miss Ohio, and so she had done belly dancing as Miss America. And so she was fabulous. And the ballroom dancing, it was hilarious. This was one of our CEOs, and she had her husband dancing with her, and she came out in a lab coat, and he was a donor. And then she rips off the lab coat and throws away the blood set, and they start dancing. It was really funny. So, but actually the person that won this, God Bless America, she works at a blood center. I think she does maybe PR or something. But while she sang this God Bless America that really brought tears to her eyes, but while she was singing, up on the screen, she told her story, and it ends up that she had one of those placenta things, placenta creta or placenta previa or something, and she almost lost her life in childbirth, and she had 20 units of blood, and it saved her life, and so she committed to somehow give back, and so she's since then worked for 20 years in the blood banking industry. And so it was really a beautiful, one of those touching stories that just tears at your heartstrings. And then the rope tricking on the left, that's one of our CMOs. And it ends up is the world, number one in the world for large rope circles or something like that. And so, I mean, just the talent, you just never know. Okay, so what's the elephant in the room? Well, the elephant in the room is when we talk about what's the state of the blood industry, you can't really talk about it without some things like this, some really kind of nasty slides showing blood utilization going down. And we did hear this morning all the attention that's going on as far as patient blood management. And I guess I would just caution that we don't want to overdo it. And I say that, I know I'm going out on a limb saying that, but I think some of our outcome measures have got to be the outcomes from not having enough blood. And it's not to say that there isn't somewhere to go as far as, giving the right amount of blood, but I think that's what we need is the right amount of blood. I guess that's just my only proviso as a clinical person. We want the right amount of blood. But we do have, when you look at international statistics and even look in north to Canada, we are giving a lot more blood per 1,000 population than other countries are. So we definitely have somewhere to go with that, and it looks like in the last 5 years or so we're really making strides. Red blood cell transfusions in the United States, you can see the transfusions are really going down about since 2008, and you can see that we're down. The last number data point here is 37.6 RBCs per thousand, but when you talk to people in Canada, Europe, they're below 30, so they, that means that there's a big disparity there between the United States and these other countries. And then you can see also the cost pressures, the cost is going up as we add all these tests that have taken place in years. And so what is happening when you look at ABC members and red cells, you can see that really our collections are, of red cells are going down. And actually that fits back to the plasma issue, because if we're talking about having plasma from whole blood donations and our whole blood donations are going down, then our plasma is going down, and we have patients all over the world that need this product. So the red cell demand tracking by year, if you look at it, I was just talking to somebody, they were saying, boy, our red cells have gone down about 20% in the last 3 years. Well, that's not so far off from what's happening at the national level. Starting in 2010, 2011 there was a slight decrease, 2012 bigger, but the last couple of years, 2013, 2014, we're talking 6% decrease, 6% decrease. That's over 10% in 2 years. So definitely it's going down. Here's just a look at platelets and what's happening FFP for transfusion with our members, platelet products. And if you look at platelet fees, we've got some data on that. But I think all that stuff is really not so interesting. I think this is what is really a serious chart. And that is, we survey our members every year, and we are doing what is called a financial ratios survey. So we really look at financial performance and all the different, there's a number of different well-accepted financial ratios that will give you information about a company's financial picture. And so what the dark line is actual data of negative margins and what percent of our members are operating in negative margins. And this is total. This is not just red blood cell. I mean, everybody would say, oh yeah, well the price of a red blood cell, bag is, I don't know, $180 or $200, and we're losing money on that, we're making money on this. But in this last year, 23% of our members overall were operating in negative margins. So that is really a serious economic picture. And that's why it goes back to that value of blood. This is not sustainable. And we have a lot of mergers, we have a lot of acquisitions, we have a lot of changes. But even then, those continued pressures on cost and the increase because of advancing technology, which is a good thing, it really cannot be sustained. And we've had a lot of merger activity. So since I'm talking about what's happening, I went back as far as the numbers went back. And so if you just look at all this, I mean, you can see it's kind of accelerating. It's like it's screaming at you. Merger activities in 90s, you can see, look at how the writing gets a little bit, here it's nice and big, and then in 90s it gets smaller, because I wanted to fit it all on one slide. And here it's like, really. And then this is just, it's just accelerating. So I decided to take that data and make it into a nice bar graph. And so if I do a trend line, you can see that the number of mergers and acquisitions are really going up, and I did it by 5-year intervals. Okay, so what's the bottom line? Well, the bottom line is we're in a permanent whitewater, and this is the social, economic, political environment we're in, and frankly, I'd rather be in a raft with a bunch of people rather than just by myself in a kayak. So I think that's the value of all of us coming together in things like this, so we can all look at the current state and kind of figure out how we're going to go forward. So the blood economy, in summary, is marked by some negative margins, 23% of our members. And we're not really addressing the insurance value of blood that I talked about earlier. We're compromising our surge capacity. We're definitely causing hesitation as far as adoption of innovative new technology. And all of those things, to me, are a big red poster saying the sustainability of the blood supply is in jeopardy. And I don't think I'm being Chicken Little. I think that no one else is looking at it because we're just a little sliver of healthcare, but we see it, and so we're kind of uneasy, and we're saying, well, this doesn't look good, and that's why we're trying to get this study done, get it in health affairs, so that we kind of take it out from under the mushroom patches and we do something about it. Now, the ABO, which is an international group that ABC is a member of and ARC is a member of, and it's a small group, it's kind of more academic group. They have proposed a model, a risk-based decision-making model, that if we use this for every decision, theoretically, we would not get unfunded mandates that don't really add a lot to the safety but cost a lot. So this is one suggestion, that maybe we could put a damper on this, increase cost, decrease reimbursement, if we all adopt a risk-based decision-making model. So that's one idea. So I thought I would do a little case study for the group on one little thing that is out there, because there are many of these things. There's Babesia, I could just list 10 slides of things that are out there that we have to look at that could impact our cost and how we do business. But I thought I would do this one because it's recent. Pathogen reduction has been approved recently. Some folks in the room are probably part of groups that are gonna be starting to use this in conjunction with CIRRUS. And so I thought that this would be kind of interesting example of something that plays into really what we're talking about in the current state. So I'm going to report to you some results of an ABC survey hot off the press just this last month. And we decided, since pathogen reduction was approved, that we would survey our members and we would ask them what they think their hospital's position is on it. And then we would ask them to send the survey to their hospitals and ask them what is their position on it. So we thought to start with doing a gap analysis of our members' perception of hospitals and hospitals' actual beliefs would be interesting. Just to see, are we all together now and how we think about things. So we used a 5-point Likert scale non-parametric statistic, and it was a convenience sample. So it's not like perfect science, but I think it's telling. So we ended up with, actually now we have more than this. We have like 53 centers that responded because I submitted these slides a couple weeks ago. And I know we're up to like 260 hospitals, something like that. We've had really a lot. Actually, I think it might be more than that now. So we've had a good response. So who answered the survey? Well, we had in the blood centers on the left, a lot of blood center administrators and blood center MDs. They made up about 85% of the responses. And then clinical folks made up the rest. And then from the hospital, the blood banking administration was 34%. Blood banking MDs were about 16%. Blood banking clinical people were about 37%. And then we also heard from hospital MDs, like anesthesiologists and maybe internal medicine, ID, and then hospital administrators. So the majority really in hospitals were people that should know because they're blood banking people. So one of the simple questions we asked is, and remember we've got almost 300 hospital responses, so I think this is pretty interesting. To which patients would hospitals provide PR platelets? And I will say in general, our survey results, the blood banking center responses were much more pessimistic than the hospital responses. So that was interesting. The blood banking responses were much kind of more cynical about how the hospitals would view it than how the hospitals said they would view it. So in this case, the blood banking centers said that only half the hospitals would use it for all patients, and the hospitals said almost 70% the response was that they would give it to more than half the patients. It would be about 70% of patients that would get the PR platelets. Now, I thought this was interesting. The blood, I tried to color code this. It's probably clear as mud. But the question was, are hospitals aware of pathogen reduction? So the blood center responses, 0 responses said that the hospitals are very aware or extremely aware. And the hospitals, they had, about 25% of the responders said hospitals are very aware or extremely aware. So that was a difference. The blood centers basically think the hospitals either don't know anything or know very little about it. And there's a certain percent of the hospitals that feel like they do know a lot about it. So there's a different perception definitely about how much hospitals will pay. The blood centers felt that hospitals, about 60%, responded hospitals would pay 0. And hospitals said only 32% responded that they would pay zero. So it sounded like the hospitals are willing to pay something. Now, a lot of the response on the hospital part, as you can see, said they would pay 10%. So that was the biggest response, this dark blue, 10%. And so the blood centers then said, you know, a lesser response would pay 10%. But I think the really important thing here is that's not enough. So even though the hospital said, well, we won't pay 0%, we'll pay something. But when you look at it, if you add 32% plus this 50, whatever it is, 55%, it's almost 90% of the hospital responses that you're gonna pay 10% or less. So almost all the hospitals are saying, all we're gonna pay is 10% or less. And what we're hearing, and I don't know if there's anybody from Cirrus in the room, but we are definitely hearing it's gonna be more than that the increase is gonna be more than that. So that is a predicament, really, for us. And this is not unique to pathogen reduction. This is any new technology. I think these are the pressures that I talked about earlier in this presentation, and that's what's leading to this. Everybody is just they're against the wall with cost. I mean, hospitals, I forgot what percent of hospitals, they're at like 3% margin or less, that's not even break even as far as recapitalization of your enterprise. And then I showed you with blood centers, so it's not like people are just holding back, it's just really tough. Okay. Now, I'm a big believer in top box, and top box is when you have a Likert scale 1 through 5, that's the 5, or it's the 1. I think that's really a commitment. If somebody says that, then they are really saying, I will do this. So a lot of times people merge the 4s and 5s, and they say, well, that's positive, yeah, they're gonna do it. But, you know, absolutely, very likely is a commitment. A lot of people really think about answering that, whereas somewhat likely, you know, a lot of people can say that, it's like, no big deal. So I did a top box analysis of the different answers, and the blood centers are the red, the hospitals are the blue, and so the gap is the purple. And so the biggest gap in perception is with the current risk being a reason to use pathogen reduction. So about 50% of hospitals said, yeah, that is, you know, 50% said current risk is a good reason to use pathogen reduction. But the blood centers, it was about 20% said hospitals would say that. So the reason this gap analysis is so interesting is I think it points out the need for really, in light of all these technological advances, blood centers have got to improve communication with their hospitals and hospitals with their blood centers so they're on the same page and go forward together. So that was the biggest difference. Future risk was a fairly big gap as well. If the FDA requires day 4 or 5 bacterial T testing in the blood bank, would that lead them to use it? That was a big gap. So those were kind of the big 3 in terms of gaps. Okay, so now let's talk about some of the actual questions and how they were answered. Now again, I like top box, so the red bars are top box, but just for those of you that say, well, I never answer top box, that's really not accurate, I did put together likely and very likely in the blue line, so if you'd rather look at that number, you can look at that number. But the trend is really the same as far as prioritizing these things. So we asked the hospital, what would be a reason you would be very likely to not use it? So what would cause you to be very likely or likely to not use the pathogen reduction? And so the number one thing was cost. Almost 22% of hospitals said they'd be very likely, this is top box, to not use it. So I would go to the bank with that. The cost would be the thing. The next thing, which was kind of surprising to me, was safety concerns about pathogen reduction. Not safety concerns about pathogens, but about, is there some unknown thing out there? Is there something that later we're going to find that it inhibits a tumor repression gene or something that later people are going to come back and sue us and say, well, this caused me to, develop cancer at a young age or something. So that was a pretty large percent. Then the concern about multiple inventories, not giving it to everybody, so you have to maintain multiple inventories. 13% said that would be enough to have them very likely not to use it, and then so on and so forth. So the big one really you can see is cost. See, now I'm just talking about what hospitals said, not what the blood bankers thought they would say, because you can see there's a big gap. Okay, so then we asked the hospitals and the blood bankers what they thought hospitals would say. What would make you very likely to use? So again, top box is the red. If the FDA were to approve 7-day platelets, then that was a big plus. 54% of hospitals said that would make them very likely to use it. But also the current risks of pathogens was pretty high, 50%, so that would make them very likely. Eliminating, if you could eliminate BAC-T testing, that was up there. Future risks was up there. So those were kind of the top ones. But I guess what really stood out to me is we said, would you be very likely to use it in the absence of AABB, CAP, or FDA requirement? And only 4% said if there was no requirement, we would be very likely to use it. So to me, we really are talking about trump cards here. And I think the trump card is that only 4% of hospitals said they'd be very likely to use it in a situation where there was no AABB guideline or recommended practice, there was no CAP requirement, there was no FDA guideline. So, and then if you're one of those people that likes to combine it, only 22% said very likely or likely to use in that regard. So does that trump those other things? I mean, 50% of hospitals said the current risks were a reason to use it, but only 4% say they will use it if we don't have some type of a requirement. So we have to figure out what that means. And then the cost, I think, again, is 21% said not very likely to use due to cost. And so does that trump the other things that they said were good about it? And what if they say, yes, I am willing to pay for it, what are they willing to pay? And what we're seeing is that the combination, we've got 87.3% that say they're willing to pay nothing or up to 10%. So these are really issues that industry, blood centers, hospitals, we all have to work this through, because we can't be in silos about this. We have to work this through. So what are some out-of-the-box approaches to funding pathogen reduction and other innovations? This was just an example. I think I could have substituted anything in those slides. We happen to ask about this. Well, one is the ABO, they came up with this risk-based decision-making model. So do we put these types of technologies through a risk-based decision-making formula and figure out, per adjusted life, if we introduce this and we have different assumptions. And I've heard some papers on that. It's pretty hard to nail down really data points on that. It is. What is, the cost of a life? Well, there's some ideas that are out there in the literature about that. What is the risk? That's a little harder to nail down, to really get an economic model that nails it down. But that's one approach. Another approach is to lobby for passing through the costs or carving out the costs. And there really are models for that. People say, oh, we're never going to get that, the government's never going to approve it. I don't believe that, because right now, in anesthesia, for example, there is a pass-through of a cost for rural hospitals, that the cost of anesthesia services has been now for probably 15 years passed through the DRG system, and so it's cost-based reimbursement. It's totally out of the system that everybody else is following, because they do so few cases that an anesthetist couldn't really survive doing one case or two cases if it was the normal DRG, and anesthesia is actually not even really DRG. It's a totally separate, weird way of getting paid, but it's a per case, per acuity, per 15-minute time interval way of getting paid. And if you do two cases and each one lasts 45 minutes, you're not going to be able to survive. So that won't work. But if you don't have anesthesia, then you can't have surgery, you can't have a hospital. So, it all kind of fits together. So there is a pass-through. And actually, right now, there was just legislation proposed to expand that pass-through. And so it's not like it's some old idea. This is still, people are still getting, if you can persuade Congress, if you can persuade CMS, then it is something that is out there. So I think that's one thing. The utility model I mentioned earlier, should there be the normal commercial interaction between blood centers and hospitals, plus should there be an overlay of some federal funding for infrastructure support? And there really is that. There are other examples of that, where that takes place. The military, for example, is paid from CDC. I mean, the military, their job is protect the country, all that stuff. But the CDC, there's federal money going for the military to have more people than they need in the event that the CDC needs to surge and they need to protect stockpiles and all that stuff. So there are examples where we can make an argument for national security and for surge capacity that we need a federal overlay for the infrastructure in blood centers and hospitals that collect blood. And then I think a very unique thought that just in our talking to people has been discussed is, should we go as an industry for an antitrust exemption? And what this would mean, and I say this is possible, because Obama and the ACA got a huge antitrust exception for their vertically integrated healthcare delivery models, the ACOs. You know, it used to be you couldn't collude, you couldn't have physicians and hospitals and everybody all together saying, this is what our price is, we're gonna bid this way. It all had to be, you know, and imaging centers and all that stuff. But there was a huge exception. So what this would mean is that we, the industry, so American Red Cross, ABC, we could get together and we could have a medical panel, and they would say pathogen reduction is for the greater good of the United States. And so we are all gonna do pathogen reduction, and this is what it's gonna cost. And we could do that if we had an antitrust exemption. So that's just another wild, hairy idea, but these are all wild, hairy ideas. So these are, I think, out of the box. Some not so out of the box is the hospital pays the cost. Just charge the hospital more and they've got to pay it or they don't get it. Well, I think a lot of hospitals are negative margins, a lot of mergers and acquisitions. I'm a hospital executive for a couple decades. It's not so easy. I mean, we never really cared about the market basket. We just cared about trying to get everybody we did business with to charge us less, because we were, you know, we had a lot of lost leaders, a lot of programs that were losing money. So maybe we don't do it that way. Maybe hospitals don't pay the cost. But what if every unit of blood in the country, hospitals paid $1 a unit of a tax, you know, like a road tax, and that went into a technology fund, and so that went to fund new technology. I mean, that's a different way of looking at it. What if blood centers paid the cost? What if you just eat it? You know, you just pay whatever it is per unit of blood center adds it. Well, I showed you 24% negative margins, so that number is gonna go up. And we continue to have mergers and acquisitions and new collaborations and all that stuff, and that's the normal churn in an industry. But that really, we have a more fundamental problem. That will not solve the fundamental problem, and so we need to find a way to do that. What if the manufacturers reduce the cost? What if we say, you know, we just can't afford this and your margins are 30%, 40%? I mean, it's all public information. And so it looks like you have better margins than we do, so why don't we work together to get this to something we can afford? And I think the answer would be, well, we've spent, and 20 might be conservative, years in research and development. We've sunk all these costs, and we've got lost leaders too, and we need to get this money so that we can pay for more R&D, so that the United States stays ahead of the curve. So everybody looks at what's in it for me, and those are all reasonable ways of looking at it. So is it going to be a combination of the above? I mean, can we squeak by with this one, with pathogen reduction, by doing some of all these things? And, you know, maybe we can eliminate some other costs and reduce some of the testing, eliminate irradiation. Maybe we can have 7-day platelets. I mean, are there some things we can do so we take there's some trade-offs, and then we can, and maybe manufacturers reduce a little bit, maybe hospitals pay a little bit more, maybe blood centers eat a little cost. So is that going to happen, and will that work? And maybe it'll work this time, but it can't keep working. Insurers, should they increase payment? I mean, can CMS take steps? And right now, I know that there's an effort from Cirrus, and I've been working with them to support their effort to establish some temporary Q codes that ultimately may lead to permanent codes. But I'll be honest, as a hospital administrator, it doesn't mean so much to me. It's something, and I think we need a multi-pronged approach, but we're still gonna try to reduce the cost of the blood center. We're not gonna say, oh yeah, we're getting a little bit more money in our reimbursement. And this is really for outpatient, because the inpatient is all a DRG. So offsetting the costs, I think, holds promise. You saw that the 7-day platelets it resonated with hospitals. They thought that was a good thing. So if we can kind of do a combination of these things, that would be good. The paid donors, somebody said that to me. They said, you know, we can transform this whole thing. If we paid donors, then that changes the whole economy. And we would be then charging for blood just like you charge for pharmaceuticals. I mean, some drugs cost $50,000 for a month's dose. Some drugs cost $100,000 for a month's dose. And blood, there's nothing like blood. That's what's so amazing. You know, one of the think tanks we talked to was the VBID out of University of Michigan, the Value-Based Insurance Design Group. And when we were talking, I was telling him about blood and what we charge for it. He was just incredulous. It was the internal medicine doc that runs it. And he said, you know, that's the second thing I have found in healthcare that is low cost and high value. He said everything else is high cost, low value. But aspirin and blood are low cost, high value. And we have to figure out a way to write a paper on that. Because if you invented blood today, it would be so expensive, because it truly saves the life right there. I mean, in your hands, you have a patient that's dying and you give blood and they live. And how many drugs can you say that about? That 100% that they're gonna live if they get this. So it's so valuable what we do. And yet it is being commoditized because people are so used to it, they kind of take it for granted and don't really think about it. And yet we're introducing drugs that save like 10% of people with this little kind of special kind of cancer and cost, you know, in the tens of thousands of dollars. And so blood, it's really an unusual therapeutic intervention in that way. And he made a very good point about how low cost it is and how life-saving it is. So here's some ideas that are out there. So what are the preliminary conclusions that I am gonna leave you with? My first is there's an urgent need to study the gap in the blood economy. The gap between what needs to be there to sustain a safe blood supply and an evergreen blood supply and the current state. And then this will inform us as to what the ask is. What should the reimbursement model be for the future state? This is the biggest contribution to population health that we, the blood community, can make, is solving this problem. It will transform really the future. My second conclusion is the perceptions of blood centers and hospitals are statistically different. This isn't really a conclusion, it is a statistical fact from our survey across multiple domains. I mean, we were more different than together in our perception. My third is the willingness of hospitals to pay an increment for PR platelets and probably for other technology is significantly less than the cost. And then my last, and this is a conclusion, is there needs to be a defined communication plan with broad stakeholder engagement of hospitals, their suppliers, and blood centers. It appears urgent that we do that because this is just one example of a myriad of future examples. I thank you for the honor of presenting to you today, and I am supposed to conclude at noon, so if there are any questions you would like to ask, I'd be happy to answer them. Yes, the gentleman in the front.
Yeah, Christine, thanks very much. Very nice talk. You did discuss, and I think it's important, what Europe is doing in terms of cost of PR, because they're doing PR in Europe. How are they funding it? At these national blood programs. I mean, that wasn't mentioned at all in any of your slides.
Yeah, the question.
We actually have kind of a overabundance of blood centers. I mean, I remember when Holland had 55 blood centers, and they shut 45 of them down.
Yeah.
And they have a national blood program. So how is Europe paying for PR?
Yeah. Well, I just heard a few papers from Europeans, and all of Europe is not doing PR. And some of the countries, like the Belgian Blood Service, is it the Walloons, the northern part of Belgium, have looked at it and decided, no, south, oh, well, the south, that's the French one. Well, then it's the northern one, the Flemish.
Right.
Yeah. They are not doing it. They've looked at it and feel that it's not cost effective. But there are a number of countries that have, and when I ask them how they're paying for it, they say, well, we're really a cost-based reimbursement system, that we have one central administrator for blood, and so we tell them what it costs to provide the service, and we try to be good citizens and cut costs where we can, but we don't have the pressure you do in this competitive environment to cut costs. So I think it is a different model. They have national health. I mean, if we had a national health system in the United States, it would be a totally different economy than it is now. Of course, they have taxes that are 60% and et cetera, but I don't know if anybody else has a better answer. It's just because their underpinning, their fundamental healthcare system is different. So blood is just a component of that, and they pay for healthcare through a single healthcare administrative body at the government level, and they tax to pay for what the cost of healthcare, and everybody has healthcare. So, yeah, good question. Any other comments or questions? Okay, well, enjoy lunch, and thank you very much for the privilege of being here with you.
Thanks a lot. Now you know why Baxter got out of blood business. I ran several for years. They tried to apply a drug. Unless you make it into a drug, you're not going to in this country. And that also speaks to the fact that the model of this country is completely broken. Completely broken. Because, here you've got all these places. I understand you guys are all using the blood centers. But the system's crazy. You got 20 blood centers even now. Well, in a way, but not very efficient.
Yes, I'm under that. You know what I mean? These are members of Congress. And I think that, yeah, I don't know why people are marching in the streets with burning. Or 70%. It's nuts. You know what every hospital is doing. So one last point, you're talking about heart, and you know Mike Fitzpatrick. So Mike is at Cellfire, he got heart attack. So you talk to Mike about it? Maybe you talk to him about the heart contest. It's funny if you talk about all the people that are around.
Good luck with the wedding.
Oh, yeah. Next time you see me, I have a very daughter. Okay, I'm ready. Is this the first wedding? No, my second one. Okay. I have 3 daughters and I'm waiting for a wedding. Oh, I have 4 daughters.
I won't keep you, I know you're running out. So I came in very towards the end. We're seeing some of this stuff.
He says you're not going to give me a hug?
No hugs. No hugs, but other than that.
See you, Rob. How are you?
Yeah, so we'll congratulations.
You said something about, you got to get all this. I would hope you have all the
I do, I have a million little details. Yes, I have.
Bring it here.
And they all said, not nothing unless it's either required or there's a decrease in testing offset.
Just talking around.
And I mean, and so for blood centers, if they hear,